Fantastic. Welcome, everyone. I'm Christina Wyatt. I'm a nephrologist and a clinical investigator at Duke, and I'm going to be moderating this today's webinar. So we're excited for this joint presentation between ISN and KDIGO, and we're going to really try to hit some of the highlights from a Controversies Conference that was supported by KDIGO, focused on women and kidney health. This was a lively 2.5-day conference, and we're going to try to give you just some real highlights from that discussion. So 2 day, really focused broadly on issues from sex and gender differences and disparities in kidney disease and kidney disease risk and management, all the way to really reproductive health issues across the lifespan. So this was a really broad topic. And again, we're not going to touch on everything today. The conference report is actually expected out fairly soon in Kidney International. So keep an eye out for that if there are areas that we don't get to today that you're particularly interested in. They are likely to be covered in that conference report. So with that, I'd like to just briefly introduce the two speakers for today. The first is Sophia Ahmed, who is a nephrologist and professor of medicine. You can see her on the screen here. She's at the Cummings School of Medicine, the University of Calgary in Canada. She is a leading expert in sex and gender-based research in kidney and cardiovascular health, and she chairs the Women's Health Research Group at the Leiden Cardiovascular Institute. Her work focuses on the inclusion of sex and gender in clinical research, and Sophia is actively engaged with international networks to improve equity in medicine. Our other speaker, Professor Georgie Piccoli, is unfortunately traveling right now, so she's going to join us towards the end of the webinar when she gets to the airport. Georgie is a senior nephrologist and researcher at the University of Turin and the Centre Hospital Le Mans in France. She has published extensively on pregnancy and kidney disease, health inequalities, and gender-related differences in nephrology. She is a passionate educator and advocate for global kidney health, passionate being the key word. If any of you have met Georgie, passion is one of the words that I think of first when I see her. She plays an active role in ISN initiatives, including mentoring and gender equity programs. So with that, I wanted to there are a couple of announcements, just a reminder about the next World Congress of Nephrology, which will be held in March. And the abstract deadline is coming up in the fall. So the deadline will be on October 22nd of 2025. So that's a great destination for folks who haven't been to that part of the world. It's on my bucket list. So hopefully to see some of you there. All right, so I think we're going to start with our first speaker, which is Sophia Ahmed.
Great. Thank you so much, Dr. Wyatt. And I'm just going to open up my screen. Great. Okay, well, thank you so much. I'm truly honored to be here today as part of the KDIGO Controversies Conference organized by Dr. Wyatt and Dr. Piccoli. I was privileged to be one of the co-chairs with Dr. Angela Webster at the University of Sydney for one of the groups and really focusing on sex and gender differences and disparities in chronic kidney disease and how sex and gender do impact both kidney health and risk of kidney disease, and really want to acknowledge the outstanding input from all participants in that truly incredible Controversies Conference. So in terms of disclosures, there's not a lot of money in sex and gender. In fact, there's none. So I do hold positions for all of these organizations listed here, but they are all volunteer positions. So just want to highlight that. I also want to say that I will aim to use person-first and inclusive language in this presentation. I can always do better, so please feel free to bring it up in the discussion or message me privately later, and both of those things have happened. I will obviously, for the purpose of this talk, be focusing on sex, biological factors, and gender, sociocultural factors, and how that influences risk of kidney disease. But I do want to acknowledge that, of course, none of us are only sex and gender, or none of our patients, that, there are so many intersectional factors that influence our overall health and certainly our kidney health, and some of which are listed here. It could be our age, it could be where we live in the world, it could be our cultural values, etc. So I just want to acknowledge that. But of course, the focus of this talk will be sex and gender. So it's not just me, it's not just Dr. Wyatt and Dr. Pickley or us or the participants at the KDIGO conference. But as you can see that the most recent KDIGO 2024 clinical practice guidelines for the evaluation and management of CKD, for the first time ever, there was recognition and acknowledgement that both sex and gender across the lifespan, so certainly from the very young to the very old, do influence risk of kidney disease and should be taken into account by we practitioners when we are treating the person who is living with kidney disease. And again, our colleagues from the ERA have recently published a great article in Kidney International, just talking in recognition of the sexual dimorphism in kidney health and disease. So I would urge everyone on this call to take a look at that outstanding publication. Now, this is an audience who's very well aware that sex and gender are not interchangeable terms. And I do recognize in languages around the world there is not always a difference between those two words. So sex in this case talks about biological factors. So this is anything to do with our genetics, immunology, reproductive organs, genitalia, and the adjectives male and female are appropriate to use with biological sex-based terms. But when we talk about gender, it has no biological basis, but does interact with sex. And it's all socially constructed roles and identities. And the social scientists are actually quite a bit ahead of us in medicine, talking about gender, and have stratified it into 4 different categories. So there's gender roles that we consider, and again, this differs around the world, what are appropriate, if you will, or expected gender roles. So who should be the primary, or who is commonly the primary earner? Who is responsible for childcare or elder care or domestic responsibilities? Then there's also gender identity, and that's just our inner sense of self, which may or may not be in alignment with what it says on our birth certificate. So for example, someone who is cisgender, their birth certificate, a cisgender woman, for example, would say female, and they would identify as a woman. Transgender is often an umbrella term that's commonly used for any identity that does not align with often what it says on our birth certificate or sex assigned at birth. And so these might be people who identify as transgender, gender non-binary, agender, gender fluid. And it's important to recognize that someone's gender identity can change over their lifespan. Gender relations are how we interact with each other depending on our own gender and the perceived gender of the person in front of us. And so how that relates to nephrology, this might determine whether, depending on what we perceive to be the gender identity or the gender roles of the patient in our clinic, we may decide that they should have referral to nephrology or not have referral to nephrology, or they should be referred for transplant, or it's appropriate to initiate dialysis, and what type of dialysis, or what types of treatment we offer that person. And we may not even be aware of our internal biases. And I really want to emphasize everybody is doing the best that they can. It's just we are all born with, or I shouldn't say born, but we all develop certain ways and perspectives of seeing the world, and that can influence our gender relations. And then lastly, there's institutionalized gender, and that's not something that individually we have a lot of power over, but it's the distribution of power and resources in society that disproportionately benefit or do not benefit people of different genders. So this could be things like whether we automatically include or not include people who are pregnant, people who are lactating in our clinical trials that examine the effects of different types of interventions on outcomes in people living with kidney disease, or having all gender washrooms versus only 2 gender washrooms. The way I think about institutionalized gender, if it's not something that bothers you or that you haven't noticed, it's probably not something that directly affects you. But it is important to recognize that it does play a role in how we practice nephrology. So I'm going to start with sex-based factors. And so we are all aware that, there's genetics certainly play a role in terms of risk of kidney disease and well as progression of chronic kidney disease. And so these are some high-profile journals that have recently published some excellent articles on how genetics and gene therapy can influence kidney health and disease. And most of us, we won't talk about abnormal karyotypes today, are born with 22 pairs of autologous chromosomes and 1 pair of sex-based chromosomes. And as you can see, the X chromosome is quite large. It's the green one there, and it actually carries about 5% of the total human genome. So, clearly it's an important gene or an important chromosome. But and this is 2013, so we hope that things have changed since then, but everyone has heard of genome-wide association studies. Well, up until 2013, only a third of GWAS studies actually included sex chromosomes, and specifically the X chromosome. And the reasons for this are far-ranging. So things like, well, only half the population has 2 X chromosomes and the other half only has 1, so we just won't worry about it. And even within the group that has 2 X chromosomes, there's random X inactivation or mosaicism. So throughout that organism, and this is from all organisms, if somebody has 2 X chromosomes, only 1 X chromosome is activated within each cell at each time, and it's random. And so that was thought, well, that's another reason we won't include the X chromosome. And then as an example of institutionalized gender, even for those scientists who wanted to include the X chromosome, for a long time, you couldn't actually even buy a gene chip that included it. So just to recognize that, there has been this erasure of the impact of sex at the genetic level in terms of health research studies for quite some time. But this is slowly changing. This is an editorial from a few years ago, and I really like the tagline that says, there are no shortcuts to good science. So, we are smart people. We know that sex-based factors influence outcomes, and it's time that we start including those factors into our research. And I'm really pleased to show that this is changing within nephrology. This is from 2024. And just highlighting, and I'm not talking about X-linked disorders that cause kidney disease, of which there are many, but this is just highlighting that the X chromosome does influence kidney function, does influence kidney health. And so it's important that we take that into account. So moving on to immunology. So again, across organisms, I'm not just talking about humans, but there is a sex bias in the immune response. So where male organisms have a weaker response to any given exposure and than do female organisms. And so on the x-axis here is from a weak to a strong immune response. And on the y-axis is the host damage from low to high. And so let's imagine in the setting of an infectious exposure, a male organism will have a much more host damage than a female organism, just because they have a weaker immune response. And you can think about this in COVID-19, for example. One of the reasons that men were more likely to get sick, be hospitalized, and die is probably because they had a weaker immune response than did females. However, contrast that in the absence of infection, having a really strong immune response, which happens in female organisms across the spectrum, results in a lot of host damage. And we know this from our clinics, right? So that, autoimmune disorders are disproportionately more common in our female patients than our male patients, with the notable exception of type 1 diabetes. Interestingly, this actually is not true in the setting of immune-mediated renal-limited kidney diseases. So think IgA nephropathy. I mean, we know this, IgA nephropathy, FSGS, where there actually is a male predominance in those disorders. And in fact, that's true across all renal immune-mediated kidney disease, with the glaring exception of lupus nephritis. And this was beautifully illustrated, and I would again encourage people to take a look at this very nice review article led by our colleagues at Imperial College in the UK, Dr. Hannah Beckwith, Dr. Lightstone, and Dr. McAdoo, and just highlight that, despite knowing that there are these sex-based differences, and I do want to emphasize they do change with age, so probably hormonal exposures make a big difference as well. This is beautifully illustrated by this figure that just shows that different exposures over the lifetime do change our likelihood of developing these diseases, but yet we still have a one-size-fits-all approach. And just going back to how sex hormones do play a role in the immune system. So I am not an immunologist, nor am I a transplant nephrologist, but just to highlight that in the setting of testosterone or estrogen, which we all have, irrespective of sex, in varying concentrations over our lifespan. In the setting of testosterone and estrogen, there are upregulation and downregulation of different components of the immune system, which are not taken into account in the studies and the trials that we do. So evidence-based medicine has historically been based on a male model. And again, I really want to emphasize we are doing the best we can as health practitioners. This is not meant to be a shaming presentation. We all aim to do what's best for our patients, and we use the evidence that we have. But as it says here, historically, we see that most of that evidence has been based on male models. So I'm blanking off the top of my head of what the time frame of this is, but the vast majority of cell-based studies use male cells, or they don't even report the sex of the cells. Animal-based studies, 3/4 of studies use only male models. 2/3 of clinical trial participants are men. But it actually flips when we talk about clinical care. And most of the studies have been done in high-income countries, but it shows that for any given health condition, women are more likely to access the healthcare system than men. And this is and I'm using a cisnormative and a binary model because that's what the studies have shown so far. But this is partly because women tend to live longer than men. They tend to live with more chronic disease. And also they have more reason to seek healthcare for things like menopause, pregnancy, contraception over the lifespan. But the problem is, and I use this example as an extreme, or I'm making an extreme example. This is not entirely true, but it's almost like a clinical experiment every time we prescribe a medication to our female patients because she has not been represented in that pipeline getting that drug to market. And our colleague, Dr. Amanda Vinson, who was a participant at the KDIGO conference, highlighted this. And so in recent landmark trials, and again, you can see this is a really exciting time to be in nephrology, as everyone here is aware, GLP-1 receptor agonists, SGLT2 inhibitors, et cetera. Lots of big, randomized controlled trials published in very big journals. And there is an underrepresentation of women. So if I can walk you through this study, this is the different classes of medications. These are the different types of chronic conditions people live with. And these are the major trials that have been published in the last little while. That are directly representative of or directed at our kidney populations. So ideally, we want our study populations to reflect the populations in the world who live with that particular condition. And that's called the population to prevalence ratio. So ideally, if we had a ratio, it would be a perfect 1, right? The study population would perfectly represent the population living with a condition. And that's what these red lines represent, that perfect 1. Everything on the right of this lines represents there's an overrepresentation of women, or said another way, an underrepresentation of men. And as you can probably guess on going to the left, this means an overrepresentation of men, or said another way, an underrepresentation of women. So we're just highlighting that, the mainstay of the treatments that we use that, are standard, now I say standard of care for outstanding treatment of people living with kidney disease, don't actually always include all of the people living with kidney disease, particularly women. And I haven't even, for the sake of time, gone into the exclusion of pregnant and lactating people. Or the very elderly, or we haven't taken into account hormonal status. So just to highlight, there are some gaps. And this is really important. This is American data, but many countries followed after this came out. So this is over a 4-year period, 8 out of 10 drugs that were pulled from the market because of serious damage. So we're talking organ failure or death. 8 out of 10 of these drugs were pulled from the market because they posed more of a threat for women. And this is because these women hadn't, and female models hadn't been represented in that pipeline getting those drugs to market. And so you can see, I mean, we all know this, there are clear biological differences between males and females in terms of body fat, liver, kidneys, in terms of weight and renal excretion. So drugs tend to hang around longer in our female populations, whether they are hydrophilic or hydrophobic, because of differences in body fat and renal excretion. There's differences in cardiac electrophysiology. We all know we are concerned about prolonged QT interval with many of the drugs that we have. Well, they pose more of a problem in our female patients. And of course, weight-based differences. We have pediatric colleagues in the audience. You already dose your medications based on weight. But of course, as soon as someone turns 18, it's a one-size-fits-all. So then just in the latter half of my presentation, we've talked a lot about sex-based factors, but what about gender? And I'm not going to focus too much about gender identity today, but certainly would be happy to in the discussion. Our colleague, Dr. Mohadij in New York, and colleagues published an outstanding paper just talking about how much we do in nephrology and just in medicine in general, where we think of our EGFR calculations, or our kidney failure risk equation, or our kidney disease predict equation. They all assume that sex is a binary, male or female, and they also all assume that people are cisnormative, so that the person's sex is the same as the person's gender, which is not always the case, as we know. And it's also important to recognize that gender can actually change our biology. Now, this is from our neuroscience colleagues, but just highlighting that as soon as someone knows that they are, Dr. Valerie Lakes has published some beautiful articles on the importance of nephron number and birth weight influencing nephron number. Well, as soon as someone becomes pregnant and they learn the sex of the fetus, they start to behave differently. They may eat differently. They may be treated differently by those around them once they know what sex the baby is eventually going to be once they're born. As soon as that child is born, we start using different adjectives and treating them differently depending on our perception of the person's of that baby's gender. The decision to dye one's hair, wear makeup, work in certain fields, how people drink alcohol or other substances differs depending on our gender. And all of these things actually can change our biology. And the most one kidney-specific example that is recently receiving appropriately more and more attention is hair straightening products. So, for example, products that contain glyoxylic acid, which is and hair straightening products are very common, actually causes kidney injury. So it just highlighting a gender-based decision does affect our biology, and certainly in the case of kidney disease. So let's talk a little bit about sex versus gender-based characteristics. We talked a little bit about identity. We talked a little bit about exposures that differ by gender. But what about gender relations and roles? And so this is actually a cardiovascular-based study that's based out of Canada, where they looked at people under the age of 55 who presented with an acute coronary syndrome and underwent a cardiac catheterization. And the plan was, or the outcome was, after a year, who is going to come back with a recurrent acute coronary syndrome? And the purpose of the study was to get beyond the gender identity. And again, they just looked at gender man, gender woman. But, what does this person do in the rest of their lives? And so they asked them questions. And they came up with what's called a gender score, where they asked them questions about, so are you the primary earner in the house? What's your income? How many hours a week do you do housework? And are you primarily responsible for doing the housework? So one of the authors of this study says, it's not remembering that the bed sheets, it's not being the person who actually throws the bed sheets into the wash, but it's the person who has to remember that the bed sheets need to be changed in the first place. And those of you in the audience who are that person who has to remember know exactly what I'm talking about. They talk about what's the level of stress at home, and then the BEM sex role inventory, masculinity and femininity score, which is, I'll be honest, a very old-fashioned score. It was published in the 1970s. based on adjectives that are describe people, whether they are feminine or masculine. So for example, if you're gullible, that's considered a feminine characteristic. If you are aggressive, that's considered a masculine characteristic. So lots of problems with the mem sex role inventory, but it was used. And the bottom line is what they found. I'm just going to walk you through this. So here is your the participant's gender score. And the lower your gender score, it means, and the author said that they wish they had used different terminology, not masculine and feminine, but basically it means the lower your gender score, that person has more roles and responsibilities that are commonly attributed to men in Western societies, because as I said, the study was done in Canada. And then on the other side, people who have high gender scores have more roles and responsibilities that are commonly attributed to women. So this might be more caregiving, more domestic responsibilities. They're not the primary earner, etc. And on the y-axis is the proportion of participants who had those scores. So they had just over 800 people in the study. And as you can see, let's start with the men. There's a wide distribution of scores across men participants, although it does tend to shift towards the the lower score side, but does extend all the way to 100, just highlighting just plunking in men or women. Men are not a monolith. People have different responsibilities across the lifespan, as do women. So anyway, so just to highlight that gender score does vary across men and similarly does vary across women. It's a little more nuanced, but you can see that all the way from 0 to 100 is where women participants scored in terms of gender score. And they found that so when they looked at just gender identity, who was going to come back in a year's time with a recurrent coronary syndrome? Again, these are young people under the age of 55. It was equal, 3% men and women. But when they looked at gender score, so completely independent of gender identity, they found that those people who had more roles and responsibilities commonly attributed to women, so more caregiving, not the primary earner, more domestic responsibilities, low income, those were the people who were more than twice as likely to be back in 1 year with an acute coronary syndrome. So I'm just highlighting, Dr. Gillian Einstein is a neuroscientist at the University of Toronto, and she says that the world writes on the body. So just we're born with a certain set of characteristics biologically, but just to recognize that our experiences do influence our health outcomes. So how does this relate to kidney disease? So Victoria Railton is just actually defended her PhD on Monday. So explored this in a kidney context. And so looked at the effects of both sex assigned at birth and gender identity and gender score on outcomes in individuals with kidney failure who were newly initiating dialysis. And some were doing incremental and some were doing conventional dialysis. And just to highlight, when everybody was cisgender in this population. And what she did is, so people were starting dialysis and she looked at their quality of life after 3 months of dialysis. That was it. And she looked at physical health and she looked at mental health. And the reason she looked at both of those things is they have both been associated with survival in people initiating dialysis. So, and then she further stratified by whether these people were on conventional, so this was 3 times a week dialysis, or incremental dialysis, defined as twice a week. So first, just looking at people sex assigned at birth, are they female or male? And you can see that those people who are female, when they were on dialysis 3 times a week, after 3 months, they reported that they had more strength. They had felt physically better, but they had absolutely no change in their mental health. Whereas there was absolutely no difference in male individuals, whether they were on incremental or conventional dialysis in both physical and mental health. Conversely, when she looked at people by gender score, she found that those people who had higher scores, so meaning more roles at home, more responsibilities at home, they were not the primary earner. These people had considerably higher or increases in mental health after 3 months of incremental dialysis, but not conventional dialysis, whereas our male population had absolutely no difference. So basically what this just highlights is the importance of Taking into account, this is a KDIGO Controversies Conference from 2019, highlighting that we need to move away from that one-size-fits-all approach to dialysis and meet the person where they're at and recognize that just because someone is a woman, just because someone is a man, just because this is a person with kidney failure, we should move away from this one-size-fits-all and take into account that person's values and preferences. So this brings me to the end of my talk, but if you remember nothing else, really what we wanted to come back from this KDIGO Controversies Conference is that every cell has a sex and every person is gendered. And it's very important that we take into account the sex, gender, and Dr. Pickley will be talking about pregnancy and lactation in the care and in the research that informs the care of the person living with kidney disease. So with that, I'll stop and pass it back to Dr. Wyatt. Thank you very much.
Thank you, Sophia. That was fantastic. Sort of a rapid fire there
Yes.
to get through a lot of material in a short period of time. Our next speaker, Dr. Piccoli, will be presenting. She is not here live. Oh, she is here live. Look at that. Amazing. From joining us from the airport. Georgie, are you going to give your talk live?
I think it's much wiser if we pass it.
The recording.
Yeah, because
okay.
I'm not so sure I'm on the phone.
Fantastic. So you can listen, you take the moment to listen to your own presentation that she recorded when she realized
I hate listening to my presentations, but at least I will be able to answer the questions.
Absolutely. Well, we're glad you made it safely.
I'm also glad that I landed.
These days flying can be stressful. Eugenie, I guess we'll play the recording and let Georgie listen in.
Hello to everybody. If you're listening to this registration, is because I've been stuck in some airport somewhere in Europe trying to get to a meeting in Sardinia. Well, we will but also meet with many of the persons that participated to this presentation. I had the honor of being one of the co-chairs of a KDIGO Controversy on Women and Kidney Health. And what I would like to do in this webinar is try to summarize some of the novelties or the most important things, at least from my standpoint, that came out from this controversy conference. And the first point is surely the fact that finally a high interest has been acknowledged on this issue. CKD is estimated as being present in about 3% of women in childbearing age, and without knowing the details, we estimated that probably the prevalence is the same during pregnancies, knowing also that early CKD stages do not really usually affect the fertility rates. However, type and severity of CKD are highly variable across settings, and no study has assessed the real prevalence in pregnant women by biochemical and imaging testing. So we are somehow blind. And we have also to say that sometimes we speak about fertility, that is live birth rates or fecundity conception, and different papers give different measures, and underreporting of early pregnancy loss or termination is very often, and we completely lack of data in many regions. Sometimes recently we even read 6% prevalence of CKD in women of childbearing age. Is probably a little bit too much, but this is due to the fact that it's different to infer. Usually the curve, the almost Gaussian curve that you see, is the curve at age at delivery, but has a peak in the 20s, while the prevalence of CKD steadily increases. And so if the prevalence is not balanced and we go up to 45, even 50 years, we may expect higher figures, at least in high-income countries. the distribution of CKD in childbearing age is very different, and we might come back to this during the discussion. And indeed, high and low medium income countries face different challenges and have different strains. But what was very important was the acknowledgement of a need to be fulfilled, both in ideal conditions and in less than ideal conditions. So the idea where we would like to be, all of us, is having reproductive care embedded into all stages of nephrology care, including dialysis and transplantation. All women in reproductive age should be offered balanced, personalized counseling, considering the different local, cultural, and practical situation. And whenever possible, counseling should be multidisciplinary. But we need education, not only for the patients, but also for the nephrologists, to ensure reproductive freedom that has been an acknowledged goal. Empowerment is needed, because even if this statement on the Lancet states at 75 women with CKD should not make children, we all know that is not completely forgotten. Education is needed. Please go over this fantastic work that Shilpa Jesudason and Michel Ludinevich did, putting some other experts together to provide a toolkit on pregnancy and kidney disease in the ISN. You'll find many very interesting things, including some options and some suggestions on risk assessment, because we know that even if CKD is a risk factor in all its stages, but is completely different in the early one and in the late ones. So there is a way, we will get back to that, to try to stratify the risk in mild, all CKD, even the mildest, moderate, when you have no hypertension or very well controlled, low-grade proteinuria, and almost normal GFR, but all the rest is really high risk. Counseling may be done in several ways, maybe based on warnings. Try to show the patients what is the worst scenario to be sure that the patient is very motivated. This is very protective for the physician, but may be very stressful for the patient. But you can also make a best case, a more encouraging scenario, showing that pregnancy is always possible, but may be very demanding. The difference, there is no good way, but there is no wrong way, and counseling depends upon settings, patients, and physicians' experiences. We recently proposed with a Mediterranean group a scenario-based counseling that could also profit of expert patients, in which you speak about the best case scenario, everything is fine, present an intermediate in which pregnancy is much more complicated, but in the end goes well, and present also the worst case scenario that is rare. It's very rare, but is a scenario in which the baby doesn't make it and the mother's disease progresses, and one has to be prepared to this possibility. And it's very important also not to forget all the other risk factors, including age, ethnicity, low birth weight, social status, immunologic diseases, alcohol and drug abuse, and so on, that are risk factors that are not included in these kidney-based definitions. So you will find both in the ISN toolkit and soon in the KDIGO paper many issues that we might discuss, if you want, on the different topics to touch with women who want to get pregnant. The problem is that very often women do not know they have a kidney disease or do not ask before, and we have to contextualize these fantastic theoretical issues into the daily practice. So, overall, clear acknowledgement of the importance of reproductive freedom, need for counseling embedded in care, need to education of the healthcare team, and for including counseling in our programs. And this means we have to dedicate time. Second point, we were there to try to establish common grounds, which was not always easy, but it was always fascinating to discuss it. So we all agreed that risk of all adverse pregnancy outcomes is increased in all CKD stages, even in the absence of hypertension and proteinuria. But we acknowledge the high heterogeneity of the studies, settings, and diagnosis. This is the first very important meta-analysis, and this is one of the last in 2024. More studies, but fewer when we want to have details on single outcomes or single diseases. So we can identify some different scenarios for follow-up. The ideal one, highly resourced, and this is not just income, is also the workforce. So all patients with CKD should be referred to experts whenever possible, multidisciplinary consultation, strict follow-up that can be tailored to local habits, for example, to the frequency of certain tests. And this is just the example of Italian Society of Nephrology, that is the one which tried to put together the frequency from 6 to each week according to the stage or to the level of proteinuria. And interestingly, it was pretty much what was taken and repeated in this consensus paper on glomerulonephritis in pregnancy. But what to do when you are not so rich? Intermediate, limited resources, limited workforce. At least follow the yellow and red lights. So start early. Beware of even mild proteinuria, and beware of even well-controlled blood pressure, because this is an old study of our group with Gianfranca Capito. If we have for example, let's take early preterm delivery, which is a hard outcome. If we take a baseline incidence of 1%, even the simplest at 3 times higher risk, but the combination of hypertension, proteinuria, and reduced kidney function may make this risk rise to almost half of a case. Acknowledging knowledge gaps is very important, and we have to remember that nothing is trivial in pregnancy, and even kidney donors that are healthy by definition have a higher risk of adverse pregnancy outcome, as well as simple diseases like kidney stones or interstitial diseases. So we have to think that we should follow all, even when we can. But what to do when we have very limited resources? Well, we decided not to set a real minimal requirement, because it would risk to be seen as a minimal target. There is no minimal target. There is to acknowledge a very important need and to try to do the best with the tools that we have. And let's hope that May 2025 will be a turning point. Third, CKD may be diagnosed, and is often diagnosed in pregnancy. In the ideal setting, we are all rich. The system works very well. Creatinine is a low-cost test. Well, some groups and some societies, like the Italian one, suggest that would be good to add creatinine to all pregnancies, combining this with follow-up. Also because probably we already have a rather good detection of more advanced CKD. But we have to know that early diagnosis may be challenging because everything changes in pregnancy: glomerular hemodynamics, tubular function, electrolyte balance, and creatinine goes down. So EGFR goes up, and there is no completely agreed value, so that 24-hour urine collection, that we all know is not the simplest thing to do in the clinical practice, is still the gold standard. There are two souls. Some participants thought that it's too much to ask serum creatinine for everybody, but all the team suggested that creatinine should be measured at least in these individuals: diabetes, autoimmune disease, obesity, hypertension. This is very important: previous history of low birth weight, prematurity, previous AKI, previous preeclampsia, and other hypertensive disorders of pregnancy and assisted fertilization. But others, like the Italian Society, still maintain the position of promoting screening, also on the account that asking all this question is time consuming and probably is more feasible just to add one test to those that are routinely done. Of course, this is not exactly the same in limited resources settings, and several reports highlight how severe CKD is very often diagnosed in pregnancy, and early diagnosis is often an utopia. This is an example from Mexico, where 1/3 of women who started dialysis in pregnancy and were initially diagnosed as with AKI had indeed severe CKD and remained dialysis dependent. And this is a very nice study from India saying that pregnancy may be a great checkpoint for diagnosis of CKD in developing countries. So all the group agreed that pregnancy is a very important issue, and that also diagnosis of CKD, third point, could be done after pregnancy. But again, one size does not fit all, and follow-up after preeclampsia should be organized once again according to local possibilities. It should not make those physicians that work in cost or time constrained places feel guilty if they do not go. It should just set high standards. Because studies in the US and in Europe find that there is about a 20% prevalence of early CKD when a kidney workup is done after preeclampsia. And proteinuria and hypertension are not enough to identify them in early stages. So let's think also about this. And fourth, do not forget the babies. The importance of being born small or small for gestational age has already been acknowledged among the risk factors that should prompt serum creatinine screening. But this is a relatively novel issue in kidney care and highlights an important field for future interventions. Fifth, what about follow-up? Well, some points are clear. Aspirin for all following local protocols. All pregnant women with CKD. This is very important because it acknowledges that CKD is important in all stages, in all cases. Should receive prophylactic low-dose aspirin started before 12 weeks of gestation and up to term or to 34, 36 weeks, of course, unless contraindicated. And the timing is very different and the doses are very different, but the suggestion is work with your local obstetricians. And do not be scared to start and do not be scared to stop after 28 weeks. It's a plus, but we have to give it. Strict blood pressure control. The conference participants supported targeting blood pressure at least to less than 140/90 and whenever possible to less than 130/80. Once again, to be adapted to circumstances, monitoring intrauterine growth restriction. And I put here, it's a table of KDIGO, how the different guidelines and best practice targeted these. The difference is very small, but we know that 5 millimeters may make a big difference if you go to optimization. And be sure, add or start slowly new drugs. Try to identify the best moment of the day. Check frequently. Provide easy contact with a physician. Check very frequently, also in remote. BP monitoring may be useful, but is not always available. And choose wisely, also according to the local habits. Choose something you really know well. And let's not forget about the diet. Nutritional management is often forgotten, but is very important in all pregnancies, not just in CKD. Should be individualized, patient-centered, I'm citing the KDIGO. Attention to overweight, obesity, but also to underweight and malnutrition. And monitoring the weight gain is also very important and often forgotten. In the general population, we know that healthy diets may be vegan, plant-based, supplemented, and we know that ultra-processed food should be avoided. In some cases, with CKD, such diets, like is our Italian experience, may be useful in postponing dialysis. We may discuss about these, and this has been recently acknowledged also by the Dutch guidelines. So check nutritional status, albumin levels, vitamins and iron, add erythropoietin when needed, assess nutritional habits, and avoid ultra-processed food. And let me end with a note of hope. Breastfeeding should be done, is possible. Even if we have very few data on quality of milk, experience know, and the experienced team reported that this is good for the mother, is good for the baby, and especially preterm infants should be breastfed. And with this, I'm sorry to have tried to squeeze too many things in such a little time, but I would really like to thank you all for your attention.
Fantastic. Well, I don't know if Georgie enjoyed listening to herself, but I know I certainly learned a lot or refreshed a lot from our meeting. I think that was a really great distillation of a lot of information that was covered there. So I think we're now open for questions for all of our for both of our speakers, if there are questions from the audience. And there were two questions that I think may not have been addressed that were raised in advance of the conference, although I think Georgie probably covered one question about sort of prevalence of chronic kidney disease in pregnancy. I think that one was addressed. A second question that was raised prior to the conference was that I think wasn't directly addressed here was a question about research in chronic kidney disease of unknown etiology and whether or not there's anything that we can do there. And I think that's probably a discussion for another day, but definitely an interesting and important area of research where, again, women are clearly underrepresented in research. Again, a disease that's thought to largely affect male agricultural workers, but there's definitely growing evidence to suggest that women who are both agricultural workers or the spouses or family members of agricultural workers may also be affected. So that was an interesting question, and I think probably a whole webinar in itself. So if there are other questions from the audience, we'd be happy to take them now.
So I may make a comment. I just moved because it appears that all the kids in the airport met where I was. So there was there are two questions that I had seen. One is not only about the prevalence of kidney disease, but it was the prevalence of kidney disease of unknown origin, CKDU. And I thought it was a very interesting question because it's not just the CKD that we are interested in, but in pregnancy, we find in a very larger sense so many cases of CKD of unknown origin. And this is true both in highly resourced country and in poorly resourced country. The difference I see with, I have no experience in very low income country, but working with some colleagues in Mexico and in Egypt that also work in remote areas in these countries, they tend to find severe kidney disease during pregnancy. But even in Italy, where we have a tradition of interest in pregnancy and CKD, roughly 40% of the patients that we follow up in pregnancy are new diagnoses during pregnancies. So this highlights that really how our Indian colleagues said pregnancy is really an occasion that should be exploited, because it's such a pity not being able to do something and to discover cases. And this is not just important for the current pregnancy, even if it may be crucial, but it's also important for the next pregnancies and for the rest of life. So I think it was a very good question, and I think we should really do the best that we can to use the occasion of pregnancy and of complicated pregnancy to reinvest in women's health.
No, I think that's a particularly interesting. I thought that really all of the conference attendees agreed that when there was the opportunity, if resources allowed, that screening for kidney disease and pregnancy was a great opportunity. Again, sort of a window to identify women who might not otherwise know about their kidney disease. And it's interesting at the same time, some national guidelines, I know, for example, in the US, some of the OB guidelines have actually taken out some screening, like proteinuria screening, based on sort of feasibility and low yield, I guess, was their rationale. So it's sort of interesting to see that tension between what we would ideally like to see from a population health standpoint and what's actually being done in clinical practice.
Well, there are so many stupid things that are done by healthcare systems. So many fake news and false ideas. So I mean, it's just one among all the others, but at least for a highly resourced country, serum creatinine costs $0.1, €0.1. It's nothing if it's added to other tests. Of course, if it's done self-standing, it's another stuff. But if it's, I mean, in Europe, virtually in all cases, you have thyroid at least twice during pregnancy, TSH control, and you don't have creatinine. I mean, there are things that are illogical, and probably we did not insist as a society enough to make more logical things. And this is, I mean, Italy has tried to have creatinine into the test. We did not yet succeed, but we will succeed one day or another. And if we succeed, we are not the richest we are something low, high income countries. So if we succeed, everybody in the upper level should do it. It's much more complicated where resources are very limited. But one has also to say that it's where resources are very limited that it's more crucial to make early diagnosis. And usually in these settings, the incidence of chronic kidney disease is even higher. So it's an absurd, but it's where we need it more, we do it less. So let's fight.
Great. I think one other area that people were interested in, we didn't have time to cover fully, was frequency of dialysis in pregnancy. If
well, I did not cover it because we hope to have a webinar on dialysis and transplantation. So
Fantastic.
But the idea is always the same. As much as possible, according to the possibilities and the needs, and knowing that the standards, as Michelle Ludinevich, who is the queen of dialysis in pregnancy, said at several times, the indications, the ideal urea is not the indication to start dialysis in everybody in every setting. Everything should be contextualized, but what is true is that her study showed that the more the best, and that we do not have to be scared to dialyze too much. And this is also something, because I remember when I started in this field, there was this fear that dialysis was incompatible with pregnancy. You should not dialyze women in pregnancy. It would be for sure a disaster. And now she showed that the more the best. So at least she showed the way, and she showed that we do not have to be scared to start and to do it with an intensive treatment.
So I think that answers one question that came up a couple of times is there a GFR at which we should counsel a woman not to conceive? And it sounds like Georgie would fall strongly in the camp of saying no, that they should be counseled on risk.
It depends upon where one is. If you are in a high-income country, if you have dialysis is available, you have, and is fully reimbursed, you have access to care, you know that you have severe kidney disease that could need dialysis during pregnancy, you accept it, and for personal reasons, because of your age, you prefer to have, or you decide to try to have a baby while you are in pre-dialysis. Why not? Of course, the risks may be the risk of death for the mother and the child in low or very low income countries. So there is no threshold, no absolute threshold, though. We focus too much probably on GFR. Normotension and lack of proteinuria may at least partly counterbalance even a relatively advanced kidney disease. These are things that were shown especially by the Mexican colleagues, Alejandra and Margarita Ibarra, who worked with very advanced CKD and with women that do not want to interrupt pregnancy. So it's always a question of alternatives. I would say that below 20, below 15 is very dangerous if you don't have a backup of dialysis. But again, we cannot. One of the things that were clear in the discussion in the conference is that we cannot make minimum prescription, the minimum that no one wants, just in case. We should be clear in what is really needed, and then try to support as much as we can the community to try to get as near as possible, because otherwise we will give low quality advice to everybody, which is not what we want.
Thanks, Georgie. I'm not sure who is suddenly drilling under my house, so I apologize if it's noisy here. We've got the three funny backgrounds here. There were some questions that I thought were good ones about that are sort of related to in pregnancy. If there is a decline in kidney function, you start to see progression of kidney disease, and I'd be interested in what both Sophia and Georgie have to say. Sort of, are there things to do other than increased frequency of monitoring and blood pressure control?
If I can start, I am going to defer to Georgie as one of the world's experts in this area, but if I can put a plug in for the inclusion of pregnant people in research. And the reason I say that is because we think when somebody is in our clinic and talks about, I'm interested in pursuing fertility and pregnancy, and as we all know, as Georgie just so beautifully illustrated, people who live with kidney disease have decreased fertility, and it can take years to become pregnant. And the problem is we have then appropriately, based on the research that we have, we've changed them we've taken them off their ACE inhibitor, we've discontinued their SGLT2 inhibitor, we've stopped all what I call the standard of care now in 2025 for treatment of kidney disease. And these individuals are off these kidney protective medications for years. And so they might have started with a GFR of, and make this up, like 40, and now 3 years later they're at 30 because we appropriately stopped the medications, because of course we don't want them to become pregnant while they're on these teratogenic medications. But in some cases we actually don't know if they're teratogenic because these people haven't been included in the trials. And so we know that having lower, so there's the risk of the drug to the fetus, but there's also the risk of having a decline in kidney function, having a lower GFR. That's dangerous for the fetus and the pregnant person as well. And so just this sort of automatic exclusion of pregnant lactating individuals, participants in trials, is something we really should rethink. And maybe it's appropriate, but maybe we can learn from, example, the HIV literature, where there are pregnant individuals who are enrolled in trials for HIV medications. But what they've done is they've started, so one, it's definitely informed consent. It's people at the later stages of kidney disease, and when they find, pregnancy, and when they find, okay, the drug had no adverse effects there, then let's consider enrolling people who are earlier in their pregnancy. And so this is just an approach, and just I hope people walk away thinking, okay, maybe we shouldn't it's not automatic. We're not necessarily doing the best for our patients by changing them, using the same drugs that we've been using for 20, 30 years and not trying to advance the science. So I'll stop there and I'll pass it over to Dr. Piccoli, because I'm sure you have thoughts on this as well.
Well, I would start the other way around, because I am a rude clinician and not an elegant researcher like Sophia. I would say there are some very simple things that we can do. First of all, aspirin. Aspirin is inexpensive, very low risk, does not protect from everything, but at least protects the placenta and reduces sharply the risk of preeclampsia. Aspirin low dose, yes. Then, according to what we have, blood pressure monitoring, vitamins. Vitamin D is low levels of vitamin D are associated with an increased risk of adverse pregnancy outcomes. So if one can taste them, one could try to integrate the needs wisely. But if one is in an area where, for several reasons, it's known that vitamin D is relatively low, vitamin D is also something that does not cost much and should be implemented in pregnancy. Diet. Besides the low protein diet, the particular diets that we use and that may require some kind of specific expertise, but just avoiding junk food, just avoiding ultra-processed food, just a reasonable diet makes a huge difference. And there are papers on this. So these are inexpensive things that sometimes are not done and that should be done. Then I think that there are several issues about drugs in pregnancy, but we know from the story of kidney transplantation that many immunodepressive drugs can be safely used in pregnancy, and these same drugs can be used in the case of suspected or known glomerulonephritis. And sometimes waiting for a few months will not change the story of a patient. It's not that we are trying, we try overall, independently from SGLT2 or whatever. These are drugs that work in the long run. So a window may not be so bad. On the other hand, it's very difficult from the ethical point of view due to the current regulations in most of the countries and the fact that all new drugs are labeled as high risk. It's not just a question that the company does not want or the researcher does not want. In many places like Europe, and I think also in Northern America, it's very difficult from the regulation point of view because the ethical committee will never accept such a trial. On the other hand, we should be wiser in gathering the data on all the patients that by hazard were treated by these diets, because these can move things. But this is rarely done, and we should pay much more attention to this because it can help understanding, and it also avoids in some cases that someone just for be on the safe side or what he or she thinks is the safe side suggested to interrupt a pregnancy. I have seen these too much, even recently, even with drugs that are now reconsidered, like ACI inhibitors. So I think that I agree with Sophia that this group of women is too little studied. But I think also that there are things that are not done well enough. And one for all the panelists, we discussed about a target blood pressure of 130, 135, 140, but is a low blood pressure. But still, there is this habit of keeping women at 150, 100 blood pressure during. It's a killer for the kidney, and is also a killer for the placenta. So I think one of the reasons why I cited at several moments the toolkit that Shilpa and Michelle put together with a few of us is that we need to pay more attention. This is the first issue. And we need to have time. It has to come into the core of a profession. We cannot manage a high-risk pregnancy, seeing her twice during every three months or 4 months. We have to have time, and we sometimes do not have this time. So I think we need more time than pills to start with, but we need both.
Well, I think we're actually at time. And unfortunately, there are a lot of fantastic questions, some of them that are really tough questions. I think Georgie quickly alluded to interruption or termination of pregnancy and the challenges and the discussions that you really have to have with patients about what their goals are there that I think we're not going to be able to address today. But most of the questions that we did not have an opportunity to answer today are addressed in the KI conference report that that should be out relatively soon. We were just making some final reflections.
It's out
Is
today.
It out today?
It's out today.
It was like embargoed. It was embargoed for our webinar. Fantastic.
It's not published, but I received a message from the KI editor, a guy that we know all a little bit, that said, "You're out." So it should be out. I was in the plane, so I was not able to, but I think that many questions are also on AKI. AKI, we did not speak about it, not because we think it's not important, but because we think it's too important to put it in 3 slides. But the ISN people is listening, and they can organize follow-up. And between the toolkit and uh, the big book that we tried to put together that is out. We hope that you'll have just a few more answers, not too many, not enough.
Great. Well, that's great news. So I think it will probably be a few days before that appears online, but I'm glad to hear that that it was just waiting for this webinar to take place. So thanks again to everyone for joining us, and especially to Sophia and Georgie, who I know are both traveling and doing this from unique locations. So thanks to everyone, and I hope everyone enjoys what's left of their day, which is different everywhere across the world. So thanks again. And thanks to
Thanks,
ISN for
everyone.
this opportunity.